In today's video, we'll discuss about bronchial carcinomas. In stage 1, the tumor will be less than 3 cm. In stage 2, 3 cm to 7 cm. In stage 3, larger than 7 cm. In stage 4, tumor will start spreading to other organs. Lung cancer is the most common malignancy worldwide in males and is also the leading cause of death due to cancer. Almost half of the cases occur in the developing countries. Incidence of lung cancer is declining in industrialized nations, like United States, due to smoking control measures. In India, lung cancer is the most common cancer, mostly in males. The Cancer Atlas program of Indian Council of Medical Research has revealed high incidence of lung cancer in some places of Northeast India. Now we'll see about risk factors. Smoking is the most common risk factor for lung cancer, especially for small cell lung cancer and squamous cell carcinoma. The relative risk of developing lung cancer is 30 times higher in smokers than in non-smokers. Only 5% to 10% of lung cancer are non-smokers. Tobacco smoke contains more than 300 chemicals, in that 40 are potent carcinogens. Nicotine and inorganic metals like nickel, arsenic and chromium also act as carcinogens. The risk of lung cancer is directly related to the duration and intensity of smoking. Passive smoking also increases the risk of lung cancer. Studies indicate that it may contribute to 25% of all lung cancers in non-smokers. These are some of the most important risk factors that are leading to lung cancer. Smoking. Industrial carcinogens are responsible for up to 8% of lung cancer-related deaths. Radionuclides such as uranium, radon in miners, radon derivatives. Asbestos, especially with heavy smoking. Silica. Arsenic compounds like arsenic trioxide, arsenic pentoxide, arsenic acid, and derivatives. Organic compounds, like polycyclic aromatic hydrocarbons, diesel fumes. Metals like nickel, chromium. Fibrosis, scar carcinoma, cavitary lesions after tuberculosis. Dietary factors. Genetic predisposition. Risk in relatives of lung cancer patients is increased by factor 2 to 4. Chromosomal deletions and mutations for lung cancer are 3p21 deletion, mutations of tumor suppressor gene p53, and Rb, altered oncogene expression. Cytochrome p450. DNA repair genes like ERCC and XRCC. Pathology and classification of lung cancer. The World Health Organization histological classification of epithelial tumors of lung consists of 42 different histological varieties, but all these varieties can be divided into 2 broad types. Tumors originating from surface epithelium of bronchi or bronchioli, it is known as non-small cell lung cancer. And second one is neuroectodermal cells or amine precursor uptake and decarboxylation. The non-small cell lung cancers can be further subdivided into following types based on histological features, although they do not differ in staging and treatment. Squamous cell carcinoma was the most common type before 3 decades. Adenocarcinoma is currently the predominant type in industrialized nations. In India, squamous cell cancer is still the predominant histologic subtype. There is marginal increase in the incidence of adenocarcinoma. Squamous cell carcinomas typically arise from epithelium of proximal segmental bronchi evolving through stages of squamous metaplasia. Dysplasia, carcinoma in situ and invasive carcinoma, and present as a hilar mass. Adenocarcinomas are typically located in the periphery of the lung and are less amenable to detection by sputum cytology or bronchoscopy, but more approachable for CT-guided needle biopsies. Large cell carcinomas comprise 15% of all lung cancers and present similar to adenocarcinomas as a peripheral lung nodule. Some of them show neuroendocrine differentiation, and when associated with necrosis and high mitotic rate, are called large cell neuroendocrine carcinomas. Mode of spread of carcinomas. Lung cancer spreads locally, by direct invasion of adjacent structures, like chest wall, pleura, diaphragm, trachea, esophagus, and great vessels of mediastinum, pericardium and the heart. Lymphatic spread occurs to bronchopulmonary, mediastinal and subcarinal, and then supraclavicular lymph nodes. Distant metastasis occurs to bone, liver, adrenals and brain, and to any site in the body, by hematogenous dissemination. Metastasis can also occur to the same lobe, or other lobes or contralateral lung. Rare sites like skin and subcutaneous tissue, breast, ovary, testis and thyroid have been reported. Now we'll see the clinical features of lung carcinomas. Cough is the most common symptom, followed by breathlessness, hemoptysis and chest pain. Breathlessness may occur due to endobronchial obstruction by tumor, causes collapse of a lobe, or whole lung, or pleural effusion. Rarely, breathlessness may be due to lymphangitis carcinomatosis. This is the condition where lymphatics are infiltrated by tumor. Hemoptysis occurs more often, in a central lesion. Rapid enlargement of tumor can cause obstruction of superior vena cava, resulting in facial puffiness, plethora and engorged veins over the neck and chest wall, together known as superior vena cava syndrome. Pancoast tumor is a tumor of pulmonary apex. It may cause Horner's syndrome, due to involvement of sympathetic ganglia, or its roots. Brachial plexus involvement is noted. Systemic symptoms like weight loss and loss of appetite are common. Symptoms may also occur due to metastatic lesions like bone pain and skeletal metastasis. Painful and tender hepatomegaly in liver metastasis. Seizures and features of raised intracranial tension like headache, vomiting and papilledema can occur in brain metastasis. A unique constellation of symptoms can develop in lung cancer affecting the neuroendocrine system, and skin caused by humoral substances released by tumor tissue, known as paraneoplastic syndromes. Clinical significance of paraneoplastic syndromes lies in the fact that they may precede cancer by months to years and may warn about occurrence. When they occur along with cancer, they may give a clue to underlying disease. Usually they resolve with treatment of the disease, but some neurological syndromes may persist. Paraneoplastic syndromes are more commonly seen with small cell lung carcinomas, but are also seen with non-small cell lung carcinomas. The most common syndrome associated with small cell lung cancer is syndrome of inappropriate. Syndrome is characterized by proximal muscle weakness which worsens with exercise. It can be differentiated from myasthenia gravis by electromyogram and anti-cholinesterase antibodies. Peripheral neuropathy, limbic encephalitis, and paraneoplastic cerebellar degeneration can occur in small cell lung cancer. Hypercalcemia is more common in squamous cell type of non-small cell lung cancer. It is caused by secretion of parathyroid hormone-related peptide, although hypercalcemia, due to extensive bone metastasis, has to be ruled out. Clubbing and hypertrophic osteoarthropathy can occur in non-small cell lung cancer. Thromboembolic manifestations can also occur. Chest radiograph, showing advanced Pancoast tumor, with erosion of rib and body of vertebra. This is the chart showing clinical presentation which is experienced from India. Investigation for lung carcinomas. Complete blood count, renal and liver function tests, along with electrolytes are recommended in all cases. Chest radiograph may reveal large peripheral lung nodule, or central obstructing lesion, collapse or pleural effusion. Contrast-enhanced computed tomography of chest and upper abdomen will pick up smaller lesions, which are not visible on radiographs, and also better define the anatomy of the lesion and its relation to mediastinal structures, as well as lymphadenopathy. Pleural fluid cytology helps in diagnosis in 60 to 70% of cases. Fibrioptic bronchoscopy helps in visualizing more central lesions, and also to take biopsy or brush samples. Video-assisted thoracoscopy can be used in diagnosis, staging and interventional procedures, like resection, or mediastinal lymph node sampling.